there is a focus on, med reconciliation, preventing UTIs and other preventable DVTs, other preventable infections, and making sure that high-risk populations, CHF, COPD, follow up somewhere sooner than later.
Okay.
So I think there is a lot of focus on what happens after that. And you'll see, you are going to see some post-hospitalization, maybe clinics where you get an appointment right away, because that doesn't seem to happen at the physician's office always. I don't know if we have enough staff to do that yet. All hospitals still, I think, are struggling to be optimally fully staffed. I think most hospitalists are still carrying a load above 18, 20. So.
I think that it's already here. I mean, a lot of hospitalists are already involved in post-acute care. Not all programs, but I think especially in large urban centers, they already are. I'm part of an integrated program, and so we already have quite a bit of involvement. If we're not already directly involved in the post-acute care center, we work very closely with those who are. I think that because of the cost drivers, the kind of the goals to improve transitions and to reduce readmissions and all of those drivers, that there will be a lot more involvement. Now, whether or not hospitalists will decide to work physically in post-acute care centers, I think that is in some ways a personal choice. But those who are involved in larger systematic organizations, those who will be going into ACOs, those who are part of larger multi-specialty integrated networks, that will probably become more prevalent if it's not already.
If we are managing sicker and sicker patients in subacute rehab facilities and post-acute facilities, do we have the right trained physicians to kind of manage those patients? I think that would be kind of interesting. I'm not sure if it would be the existing hospitalists or how we would, yes, I think it would have to be a partnership with geriatrics. Okay. And maybe there is something, a special or a niche set of people who are either geriatricians who work in the hospital, or it's a hospitalists who then take additional training or work specially with that population. So like in ACE units and things like that, kind of take that. So yeah, it cannot be. We'll have to find out creative ways to kind of staffing it. It cannot be the existing number of people because they're already stretched thin with the patients that we see. If we take on more, then it would have to be one additional training to kind of manage that population better.